Now we would like to invite Professor Angela Chong come to the stage with the first presentation, Head and Neck, Potpouri and review of Edidtion, because SO, Head and Neck Tumours.
So, can you hear me?
Yes.
I can't move the microphone. Can I have the first slide?
Can you wait a little bit?
So thank you very much, everybody. I'm very privileged and very honored to be invited to Ho Chi Minh City for the 14th pathology meeting. Actually, if you don't have the slides, I have the USB here. Do you want the USB?
Yes, we have. We already have your presentation, but had some
technical issues. But anyway, yes, thank you very much for the invitation. I'm very privileged, and especially as Vietnam is one of the fastest moving and fastest growing economies in Southeast Asia. And it's a very privilege for me to see the growth in Vietnam. So I'm not sure whether, can you hear me if I move out? Yeah. So thank you very much. I would like to say that I'm no expert, but so I'm no expert, but I would like to share with you some of my experience, some of my cases, because I think experience is important. As somebody told me once, experience without knowledge is blind. But knowledge without the experience is just play, intellectual play. So perhaps today we can share, and I will tell you my horror stories and perhaps save you from similar situations in the future. So let's see whether I know how to do this. Next slide, please. Okay. Whoops. So next slide. I would like to pay tribute to my mentor, Professor Chong. He was very well known in Singapore for nasopharyngeal carcinoma. And his son is now, I think, president of Singapore. So his actual PhD was in liver. But when he came back to Singapore, he made his journey to go through nasopharyngeal carcinoma, and I think there were many publications, and he also came back with lots of stories about how the international community viewed nasopharyngeal carcinoma at that time. And even in the investigation of etiology of nasopharyngeal carcinoma, there was consideration of not only viral but environmental. And some of these publications still exist today, and I still see it mentioned in some of the publications in journals, that even mosquito coil smoke, inhalants from the mosquito coil might contribute. So, there's a lot of problems with etiology when you don't really know the etiology. So I thought that we could review head and neck tumors in the ENT, in the WHO classification. And the fourth edition, the old edition, there are only 4 categories. 1 volume, 4 categories, so I thought I was quite safe. Unfortunately, this new edition, there are 2 very thick volumes, and this is only one, chapter 2. There are actually 17 chapters. So from 4 chapters, it has expanded to 17 chapters. And I think the classification they have changed it slightly. So I would like to tell you that I feel like a dinosaur because the classification has changed so much. So my case today is a 40-year-old male who presented actually to another hospital with a thyroid lesion. It was a 2 cm thyroid tumor, or thyroid nodule. And in the course of investigation, they found he had also complained about nasal obstruction. And this is from one of my colleagues, Dr. Lau. And you can see that there is a nodule in the top, in the roof of the nasopharynx. So this is a CT scan. There's a little nodule at the thickening of the nasopharyngeal roof. So there was a biopsy in another hospital, which was inconclusive. And then it came to Dr. Lau. So the usual suspects. This is one of the famous film starring Kevin Spacey, The Usual Suspects. But all the clinicians thought that this was a nasopharyngeal carcinoma. And this is from one of Shanmugatnam's publications, Schminke and non-keratinizing lymphoepithelial type. Nowadays, of course, if you do the post-nasal space biopsy, some of them come like this. You only have little small islands. And even though when I was training, as soon as you see nasopharyngeal biopsy, it is either lymphoid hyperplasia, nasopharyngeal carcinoma, or maybe what we could use to call leafo midline granuloma. And we didn't do any special stains 40, 50 years ago. But now, in my practice, I will do, in a nasopharyngeal biopsy, if I think there is something, I will do a keratin stain and I will do an EVA stain, because there are so many differentials nowadays. So NPC, as we know, usually it is keratin, it's associated with EBV, and the circulating levels of EBV we use to monitor the disease progress, recurrence, so that's very useful. The actual etiology, as I said, is viral, genetics, as well as a query on environmental. So there are many different things that can happen. This is from Hanoi, durian coffee. So again, many things can happen. This is a biopsy from my patient. It is a spindle cell lesion, and the first biopsy that went to another hospital, they did all the spindle cell stains, and it was all negative. So the report from that hospital went out as a spindle cell lesion, not non-reactive to anything, but they think that it is definitely a tumor. So I would like to point out spindle cell, not that pleomorphic, and you almost see grooves, and of course you know that this patient had a thyroid nodule. So there's a differential already coming in. The biopsy that I had was a much more generous biopsy, and you can see nasopharyngeal mucosa, the respiratory mucosa, and you can see definitely a papillary lesion. It has thin fibrovascular cores. It is covered with a single layer of cells, sometimes cuboidal, and that even though most of it is exophytic, you can see some of it going in the superficial submucosa. Again, another look at the papillary formation. Obvious, beautiful papillae, and you can see the normal transitional type respiratory mucosa, and you can see here a thicker papillae with what looks like oncocytic type cells. We also have the spindle cells, as you can see. Again, really spindle nuclei. Some of them look as though they have inclusions. Some clearing there again, some pinkish inclusions. We also have the oncocytic cells, you can see. So it looks like oncocytic, like a slimy gland oncocytic metaplasia. Again, oncocytic cells, almost like a hobnail, some of them. And then here, what looks like a squamoid metaplasia. So all this is happening in the same tumor. columnar cell almost. So it's a very interesting tumor. So no wonder the original pathologist had some difficulty. And the differential diagnosis we considered, because this patient had a thyroid nodule, was of course a papillary squamous cell carcinoma. But just to go through, we did think of a squamous cell non-keratinizing squamous cell carcinoma because it was in the nasopharynx, but obviously it wasn't, it was papillary. So what other things did we think about? Papillary thyroid carcinoma. But usually the classical would have the classical nuclear features with the nuclear clearing, the eosinophilic cytoplasmic inclusions, nuclear clearing, crowding, overlapping, some of them with nuclear groups. On cytology, you would get the thick colloid, multinucleated cells, and of course the usual clusters with the nuclear site features. Unfortunately, papillary carcinoma thyroid comes with, sorry about the slide, comes with multiple subtypes. So you can have all the features that we saw in our tumor. You can have clear cells, you can have columnar cells, you can have Wathin-like, you can have spindle cells. So basically, papillary carcinoma is not only the classical papillary, but if you are unfortunate, they can come with lots of costumes. So like cosplay and all that, they can try to fool you, and you must be careful. And in this day and age, not like when I started 50 years ago, in this day and age, we do have ancillary tests which we can use, and I think we should use them. So this is from the WHO book. You can see a tall cell, you can see columnar cell, you can see tall cell, you can see oncocytic and hotmail type. So potential diagnostic pitfalls. And then what should we do? So in Singapore, of course, we like to think of differentiation. In the nasopharynx, is it only the non-keratinizing squamous and basaloid carcinomas that we get? But a minority are also salivary gland, because you can also get salivary gland tissue in the nasopharynx. So you can also get salivary gland tumors in the nasopharynx. What different types? So adenoid cystic is one of the more common salivary gland tumors that you can get in the nasopharyngeal biopsy. Not that they are common, but common in the nasopharynx, salivary gland nasopharynx type tumors. So adenoid cystic, well known to occur within 1% of the cases. Of course, what are the ancillary tests apart from the classical architecture, cribriform with these myxoid globules? We also have the ancillary tests available to us, especially in the more poorly differentiated adenoid cystic, SOX10 and CK7, and also the MYB NFIT genomic tests. CD117, demonstration of the rearrangements by gene fusion. The unfortunate bit is that as we grow along, we see more and more sub-classifications and different types. So now we have HPV-related adenoid cystic-like carcinoma, which can occur in sinonasal spaces, and has also been reported in the nasopharynx. So this is a case from Dr. Huang Jun Xiang. They are rather more basaloid, they're rather more monotonous, but they do look a little bit like the adenoid cystic. So there are many cases, there have been several publications, of which I would recommend these 3 publications. And this is from Justin Bishop's publication in the different types multiphenotypic sinonasal carcinoma, which was previously known as HPV-related. And of note also is that just a block positive P16 is insufficient to call you do need the HPV RNA before you can call HPV related, because adenocystic in other carcinomas sometimes shows P16 positivity. So Justin Bishop's publication, the bottom line is that it needs HPV specific testing. So if you have a monotonous basaloid tumor, sinonasal, nasopharynx area, please do think of it, because if you don't think of it, you will not reach the diagnosis. You do need, nowadays, you do need a little bit of help from the ancillary testing. So HPV related, multiphenotypic. Sorry, I'm going fast because I think we started a bit late. So, again, this is from the WHO book. Your HPV RNA-based in situ hybridization must include several other HPV types, including HPV 33. Nowadays, I think even HPV 82 is involved. This is a case from Dr. Angela Thomas. You can see it is really monotonous. It tends to be subepithelial. And this one, in other parts, was adenoid cystic-like. So this is from Professor Chong, I think it's Taiwan, oops. But that particular paper gives a very nice table which gives you a range of tumors which can look similar, and it gives you a differential diagnosis and how you can differentiate. Other salivary gland tumors that have been reported in the nasopharynx or that I've seen in my practice, I mean, epidermoid carcinoma, in fact, this was the first non-usual type, non-keratinizing NPC that I saw, a glandular type was the mucoepidermoid. Mucoepidermoids, of course, as you know, has a clear cell variant, and this clear cell variant is sometimes a bit tricky because if you see only a small biopsy, you might think it is something else, for instance, a renal cell, metastatic renal cell carcinoma. But you please do think of mucoepidermoids, and of course this is a mucin stain, you can find mucin. And nowadays, of course, you see the MAML2 receptor, which is the bottom is seen in many of the classical mucoepidermoid carcinomas. Of course, we know that mucoepidermoid has a grading disparity, but again, it's in the eyes of each pathologist. And as we do more and more of these meetings, it is good that we all calibrate our eyes to the same grade so that we can all speak the same language. And when the surgeons or oncologists treat the patients, the treatment protocol can then be applied across board. I think that's more important. This is one of our visits, I think, previously, before COVID, to the Ho Chi Minh City, and this is my colleague, Dr. Kesavan, trying to separate his slides. So just to show, Watkins has also been reported in the nasopharynx. This is Watkins, and this is our tumor. So if you have a small biopsy, it may not be representative, and you might think, oh, maybe this is part of Watkins. One of the things that we have recently seen is that we have a case of an oncocytic metaplasia, a melanotic oncocytic metaplasia. So this is a stain for melanin. It's just that if you see it and you see a little bit of brownish specks, you should think of it. If you don't think of it, you won't see it. So this is again another of our visits. Dr. Cheng, who is hematolymphoid, Dr. Kwa, head and neck dentist. You might know that. And then Professor Tan breast. So this is from my patient, this current patient. We did FNA thyroid, it was hypocellular. Much of it was just thin choroid, but we had one little cluster, and this is a cluster. It is not a papillary carcinoma, it's just a cluster of follicle cells, so you must be careful of not to freely call just one papillary cell carcinoma. So this is our case, And just to remind you, we have a thin fibrobascular cores, well-formed papillae with the overlying mucosa. We have a spindle cell component. It was keratin positive. It was TTF1 positive. So as you can see, the tumor cells are TTF1 positive, and you can see the transition in the squamous component that there is also some TTF1 positivity. This was thyroglobulin negative. So it is definitely not a papillary carcinoma, because papillary carcinoma would be PAX8 positive, thyroglobulin positive as well. This is the oncocytic form, and it also stained positive for TTF1. So we think that this is a low-grade papillary nasopharyngeal adenocarcinoma. There have been several publications, and again, if you don't think of it, you will not reach the diagnosis. This is from that publication. You can see that in the 35 cases that they studied, most of them there was merging areas with the superficial epithelium, so that's where they think it arises. And there's a spindle cell component in most of them. There's some show squamous differentiation, Hocknell cells, foamy macrophages, and Samoma calcifications. But please do note there is a prominent spindle cell component. So depending on how you get the biopsy, that's how you will see it. And all of them are TTF1 positive, all of them are keratin positive, but PAX8 and thyroglobulin is negative. We have a low P67 count. There have also been publications about a cellar tumor that resemble this. So just to emphasize, you do see a spindle cell component. This is the thyroid nodule from the patient. So he had concurrently a thyroid adenoma. It was TTF1 positive, it was thyroglobulin positive, and the nuclear features were not that of a papillary adenocarcinoma. So just to go through very briefly, I think I have time, Schneiderian papillomas, first described by a fellow called Schneider. And at that time, many years ago, they thought all this mucus dripping from the nose was sweat from the brain dripping through the cribriform plate. And he was the first one to suggest that actually it originated from the mucosa. So sinonasal papilloma, inverted papilloma, we will also see a mixture of mucin cells and neutrophils. There are several forms, but please note that most of them will be in the lateral nasal mucosa. My case was a nodule, a thickening of the mid and posterior nasopharynx. So the position, inverted papilloma. Some of them will show you mucin, so to be careful that you don't overcall this. And some of them do show oncocytic metaplasia. Nowadays, it is, as I said, almost everything has a molecular component. Whether you believe it or not is different, but apparently the oncocytic type does show KRAS. So KRAS, I think you can't really use it as diagnostic. You have to have the morphology first, because almost every other tumor has a KRAS. So inverted papilloma. A differential that we consider in the nasopharynx when I was studying was, of course, the lethal midline granuloma. My teacher, Shamudana, said it was essential for us to recognize and call, because otherwise the patient has a very rapid downhill course. Of course, now we know it as extranodal and NKT cell lymphoma, and this is related also to the EBV virus. So you see a mixture of inflammatory cells as well as large atypical cells. There's also necrosis, and there is also angioinvasion, you can see there. If you do the ancillary stains, of course, CD2, EBER, and of course the activated T cells. So lethal midline granuloma, I like this term, I really like this term, even though everybody now calls it extranodal NKT cell lymphoma, which is so unromantic. But yes, NKT cell lymphoma, it shows activated T cell type or null cell and related to the EBV. I'm so happy I'm a dinosaur, and when it says complex genomic alterations means there's no one. They haven't identified any. So a differential for the spindle cell component that my colleagues had considered, of course, the usual spindle cell, they went to the muscle, whether it's rhabdomyosarcoma, leiomyosarcoma, they went to a malignant peripheral nerve sheath tumor. But we recently had a case of a biphasic spindle cell sinonasal sarcoma, which has also been reported sporadically in the nasopharynx as well as sinonasal spaces. This is, again, our case with the prominent spindle cell component. But the biphenotypic sinonasal sarcoma is usually, again, is fascicles of spindle cell, very blue. Positive for S100, SOX10 is always negative, and MyoD1 is inconsistent, SMA is positive. So if you want to draw a line, the low-grade papillary nasopharyngeal adenocarcinoma, TTF1 positive, paraglobulin negative, biphenotypic sinonasal sarcoma, S100 positive, SMA positive, but SOX10 and MyoD negative, so there's a split. I mean, it's just how I remember it. So S100 SOX10, and then of course the H3K27. Several publications on this, and this is our case, a biphasic spindle cell sinonasal sarcoma, which I received for frozen section, and I very happily called it spindle cell lesion because I didn't know what it was on frozen section. Of course, when we got the resection, you can see that there are these fascicles of spindle cells in the submucosa, very thick, going around. Valentin. So I'm a dinosaur, so S100 SMA positive, SOX10 myoglobulin negative, and the H3K, it was positive. And of course, we have the PAX3. So another thing that is quite popular amongst the surgeons is, are you sure it's not one of these IgG4 related disease with obliterative arthritis and fibrosis? All I can say is that if they do ask, you need plasma cells. If you don't have plasma cells, you cannot call it. And everybody knows head and neck, you've got plasma cells all over the place. So your lesion has to be plasma cell rich. There's a mixture of inflammatory cells, but the dominant cell is always the plasma cell. Dense inflammation, a storiform fibrosis, and obliterative phlebitis. You need all three before you can call on histology. Otherwise, you say we have one, we don't have the other two, and please correlate clinically. So again, a spindle cell component, again, when the small biopsies, depends what you get. So as a pathologist, you have to have a list of differentials, talk to your surgeon, talk to the radiologist, and apply it. So IgG4 is increased, and IgG is there, but IgG4 is increased with reference to the IgG staining. So just to go through, the WHO does show REAH, but this is the adenomatoid hyperplasia, but this is benign. Just be careful that when you see small biopsies, you do not overcall it into an adenocarcinoma. Seromucinous hamartoma, It's just a hyperplasia, but it's given a name, so please recognize it. Sometimes you do see it. I have to admit, when I first saw my first few cases, I just said chronic inflammation and left it. Of course, I was quite horrified when they started to put a name to it. And of course, the clinician is happy because now there's a name to the polypoid thing that he saw. And it's not just hyperplasia. We also had a few amyloid nodules. And you can see here very nice congruate with the apple green birefringence. So again, pre-COVID, we came here with Professor Fernando Schmidt, and I think we had quite a good time. So I think that in this very brief moment, we have gone through some of the classifications in the WHO book. And I think I should stop there. Let me see, keratinizing. Now, of course, if you have an undifferentiated carcinoma now, there are other carcinomas to consider. So nut carcinoma is one of them. If everything is negative, do consider using your ancillary stains to exclude things like a nut carcinoma. That's one of them here. I'm sure previously we called this poorly differentiated carcinomas, but now that there's a name, they identify, so please do think of it. It is negative for HPV. And again, all these small classifications, if you do not think of it, you will not call. Lymphoepithelial carcinoma, of course, is associated with EBV. Sinonasal undistinct carcinoma has endocrine type staining sporadically. Monotonous, poorly differentiated. So if you have this anywhere in the sinonasal tract or nasopharynx, please do think of these differentials. So a very brief run through of some of the cases that we have seen in the last few years, which has come up in the WHO classification. To my horror, more and more, 17 chapters instead of 4 chapters. So thank you very much. Thank you for inviting me, and I hope you had some fun listening to my problems. Thank you very much for listening to me and my problems. Thank you.